We are live.
Namaste, good evening. This is Dr. Archana Dwivedi, Midlife Management Committee Chairperson, Fogsi. And it's my proud privilege to host the podcast of 261st Gyan Pravah, the Flow of Knowledge, our vibrant President Dr. Sunita ma'am's initiative, where we all 30 chairpersons share their own space to discuss so many diversities with so many faculties around. And it gives me a proud privilege to see two stalwarts who are a epitome when we talk about rejuvenation after midlife. Something new from Sunita ma'am. I happened to visit the Alive Clinic at Bombay and Pune both. I was a privileged person. And the serenity, the newer knowledge, the NAD, and there are so many things, stem cell therapy, which has come into advent. And beating the menopause, where is menopause? It's young forever kind of a feeling when we meet madam as well. And another platform with Dr. Meeta ma'am, who is serving the humanity with the rational use of menopause hormone therapy, which is again adjuvant to give a complete boost to midlife. So welcome Madam Sunita ma'am and Meeta ma'am on this podcast for today. And it gives me immense pleasure to share, Meeta ma'am. You must be knowing we had a great time in Figo, a great impact from our Indian president. So many reviews, like a brilliant doctor on stage, the knowledge beyond comparison. So many verbatims were there when I was looking forward to the Figo feedbacks. Sunita ma'am, I would not call you Sunita ma'am, Dr. Professor Sunita ma'am. That is a privilege which I want to take all the time for making us proud as Indian doctors, and you said Foxy in every home, now Foxy in every international home. The Sampoon project, the concept which you gave us, enlightening a woman before she tries to conceive. So she is completely spiritually into that maternal well being, physically also. So, madam, you made us proud recently, and I think it's a
Thank you, Archana. Thank you. Your podcast, I heard Mitaji has to join some other meeting as well. So let's be focused on you and Mitaji. Mitaji, I joined just for 2 minutes to welcome you, to show our respect from Foxy platform for taking out your time and being with us, sharing your knowledge, sharing your experience. And I'm sure Archana will bring out the best from you. She is the best director, I should say. She will be taking a beautiful interview. This is a platform my chairperson, they cherish and they perform, they out. They outperform. They don't perform. They outperform their way of talking, interviewing, their oratory, their creativity, their passion. Everything is so palpable in their podcast every month. So I'm going to join the viewers link and will be enjoying the dialogue between the two beautiful ladies.
Thank you
Thank
so
you.
much, Sunita. Thank you, and
Thank you.
congratulations for all the great things that you're doing and what all you're bringing to India and making a mark at the international level. And all the very best, so that your tenure gets better and better, and you have
Thank
the
you.
satisfaction at the end of your tenure for the work you're doing.
Thank you, ma'am.
before
Thank you.
Madam leaves,
Thank you.
just one word. She makes it a point to join at 8 p.m. in spite of all 365 days.
I really appreciate. I mean, I was just thinking, very appreciable to be there everywhere.
May who, that is the feeling
Thank
is
you.
always there. Thank you, ma'am. Thank you so much.
Thank you. Thank you. Bye.
So taking it forward, let me introduce you, Meeta ma'am, formally to our August audience. Madam is a founder chair to Indian Menopause Registry of Research Committee 2131 for IMS and patron of Hyderabad Menopause Society, also the founder patron, I would say. She is consultant and head of department, a menopause and osteoporosis specialist, co-director of Tanveer Hospital. Many awards to her kitty. She is editor of Journal of Midlife Health 2022, chair clinical practice guidelines on menopause, chair to clinical practice guidelines on postmenopausal osteoporosis, past president of IMS 21-2. But let me tell you, she is a very humble person and I would say approachable, knowledgeable, calm, composed, and compassionate when it comes to menopause therapies, and a dedicated person who has created so many knowledge, I would say, insights in dealing with menopause in terms of menopause hormone therapy or the osteoporosis, making the lady always vibrant even after the midlife or the menopause. So, welcome, Dr. Meeta ma'am. Who else would have considered when I talk about myths which are associated with MHT? And we would, in another 45-50 minutes, we to break that myths while discussing with you. So, at a proud privilege position, I would like to fire my first question to you. What exactly is menopause and what happens hormonally during this phase? Because I have seen it's a habit whenever the lady is complaining or not even complaining, behaving erratic, people say, this is menopause, just leave her alone. So we need to be more aware. This is just a term or need to be addressed.
Yeah, I think you have just started off with the first big myth that menopause is something that you have to deal with. And I think that is a big and unfortunately, Archana, I think it's not just the women. It is unfortunately the medical professionals, the paramedical, or even at the home, the environment. And now, of course, there's a lot of talk about the workplace also, where menopause is completely neglected. And they say, yeah, this is going to go off, just like your puberty. And so it's just a phase of life which you have to go through. Everybody goes through it, so it's nothing different. We do agree partially, but we have to understand that the dynamics are very, very different when you're going through menopause. It's just like puberty. But I always, the beginning of my career when I started working on menopause about, say, 25, 30 years ago, the interest at that time. And I felt that menopause is like puberty. But unfortunately, at puberty, you're not so wise. So everybody accepts you with your ups and downs. But at this age, they expect you to be wise. They expect you to take care of everything. Whatever you're going through, there's nobody to understand you. The turbulence that goes through, especially at the transition. Post-menopause, you're more stabilized. You're kind of under control. But during that particular phase, when you're just entering menopause, is the time where the woman really needs attention. So it's not just women who have got vasomotor symptoms or problems. There are so many other aspects to the menopause at that time. And why should only, working people or the men have the executive health checkup? Why not the woman at this age? Why not every housewife? Why not every woman goes through and check up, especially at the transition? Because that is the critical window. So coming back to your first question, what do I feel? What is menopause? It's, of course, a physiological phenomena, where you're transiting, just like how you've gone through your pregnancy or your puberty, but it involves a lot of things. In the sense, you're moving away. It's probably the first sign. The first sign, Archana, do you know which organ ages first? A wild guess? I'll tell you. Don't think too much. It's the ovary.
Yeah, if it's pertaining to menopause, I thought started my brain.
Yeah, no, I just threw a question at you like that. But in the body, the ovary starts aging because you see, even before you hit menopause, the changes start about 6 to 8 years earlier. So it starts about 8 to 10 years earlier in some. So what happens is there is a slow change in your FSH and your estrogen going up and down. So there are a lot of hormonal changes. And we have to understand that unlike other hormones, estrogen is very special. It's very special. That's why, everybody has a lot of trouble understanding it, just like a real female. Yeah, it's got a lot of mysteries around it because it has receptors all over on the body, and it is a neuroendocrine effect on the body, and it has an effect on the autonomic nervous system. So all these are going to cause a lot of changes in the body. So these changes are also dependent upon so many factors. It is the basic health of the woman, the psychological being, and your complete atmosphere. So I would hear, I'm very impressed with the Bell's theory. So I'll talk to you about this Bell's theory, which is very, very impressive. So because it makes you understand the core of what is menopausal health. So the Bell's theory talks about the physiological changes that as professionals we take care. And then we consider menopause as estrogen deficiency, a disease, but not We don't believe it's a disease at all. Of course, all of us don't believe, at least not in the IMS, at least, we believe in the holistic approach. And the other part is the environmental. The environmental part is where the woman has to be very confident enough, has to, have that thing for self-help. There is nothing as important as self-help. Third dimension is the psychological, where sometimes she may have control, sometimes she may not have control. And that's when, the physiological and the psychological bit, some women need more help than the others. I think that's a long answer for your short question.
That's very, very well explained, because it's just not the stopping of periods, the climacteric phase, the perimenopausal phase, whatever we define in terms of layperson. The changes starts even 10 years before. See, after 35, that is why midlife transition is what we talk about more before you actually enter into the menopause. And that is a time where you have to have that window of opportunity, as you said. Health checkups, yes, strongly advocated. One should not buy a diamond ring. It's useless. Go for a health checkup on your birthdays or anniversaries. That's a better. That is what we all think to advocate right now. So, ma'am, when we talk about menopausal symptoms, there's a long list. Sometimes the husband is complaining, she's not cooperating. Sometimes a woman is coming. So, what is the most common symptoms you come across in your OPD day-to-day basis?
I think, this is one big area which takes a little time to understand when you start doing your menopause practice. But I think we're in a better era now, where, the symptomatology is kind of better defined. Because as you see, the menopause medicine itself has evolved over the last few years. It's not like, the pregnancy care, where things are very much settled. Whereas here, it took a lot of work, a lot of observational data. And SWAN was one of the excellent longitudinal studies where we are more sure about what fits into this menopausal symptoms. Otherwise, what used to happen was anything happened during the transition was placed into menopause, which is not rightly so. So now we have got a little clarity on that. And I think it's very important in this platform, for the young gynecologists and practitioners, to make them understand that we have to, whenever we're talking about menopause, I would encourage them, just like how much time would you take to do your antenatal one patient first time?
Almost 10 to 15 minutes, just examination history. Minimum is 10-15 minutes, may exceed also.
Yeah. So supposing she has some complications along, some pre-hypertension or whatever, some comorbidities, and then you're looking after, you may take 30 minutes also for one patient. So similarly, when you look at menopause, the first time when you see that patient, you cannot do it in a jiffy. You have to spend minimum 20 minutes or 30 minutes. So that is the first advice that I would give the practitioner, that you need to spend that time, because then you're going to use some scales. When you're using the scales, you're more objective. You know exactly what you're looking for. So you have to start using the MRS scale for the menopausal symptoms. And that clearly defines the 4 domains. So once you do that, then you know where your woman is fitting in. Then you know that it's a cluster of symptoms generally. It's never only vasomotor. But like you see in India and most of the Middle East countries and South Asian countries, the joint pains, they are more than the vasomotor symptoms. Unlike in the Caucasians, where the vasomotor symptoms dominate. So we have more of joint and muscle pains. But we have to remember that we also have the vitamin D deficiency, we have the anemia, we have the thyroid, which is quite a bit, the thyroid dysfunction. So we have to rule all of that. And then when you're sure that, everything is in place and your joint pains and muscle pains are in sync, or they have some, episodes of vasomotor symptoms, after correcting everything probably, because this is one of the predominant symptoms that Indian women face, muscle and joint. So when to treat with MHT is when you're sure that it is related to your menopause and not to so many other. Sometimes it can just be psychological, they're going through some stress, your muscles are in spasm, or it could be as simple as osteoarthritis. So you have to be sure what you're dealing with. And the GSM, of course, comes in much later, the genitourinary syndrome. But though the full-fledged GSM comes in later, the early symptom that comes in at menopause transition, which probably we dismiss it off, and where the husband is complaining at menopause transition is a vaginal dryness. It's not just the stress, it is your fluctuating levels of estrogen. And the first symptom starts off with vaginal dryness, and then slowly post, after 4 to 5 years, the full-blown picture of GSM may come in. So I think these, and another symptom which comes in early, vasomotor symptoms will set in at late menopause transition, just before, and post-menopause, where they start complaining of symptoms. And this is what I have seen in my practice. What starts off is, the mood changes.
Mm.
Mood changes are the most common. And something which is very common, if you remember, if all of us would have gone through it, where you forget where you have kept things. You forget your key, you have your glasses right there on your head, and then you're looking for your glasses. So that is the brain fog. So this is what happens in the early transition phase. And here the message is that brain fog, the mood changes generally go off, and they don't develop into any dementia and later. They're not an indication that people are going to, get into dementia just because you're not able to recall. So it's just a normal short phase which will go away.
Yes, ma'am, truly described it very nicely. So, knowing the symptoms are there, you talked about the anxiety, panic attacks, mood swings, and changes. So, I think they will be silent predictors of a future CVD risk in the patient. So, they need to be handled, but you have to be very sure that you are dealing with the menopausal changes only. So, I think
Absolutely.
it's rightly said that take out that 30 minutes. You need that to satisfy yourself also that you are doing the right thing to the patient. So, ma'am, what motivated to you to establish the midlife registry? I know this is what we know, Meeta ma'am. Midlife registry comes automatically into the picture.
Thank you so much, Archana. Actually, my interest in menopause started off early part of my career when, we used to have a lot of these women castrated. I use that word, castrated. For as simple as just white discharge, pain, abdomen, no indications. So young women, at the age of 35 and 40, having severe problems. I mean, they're in a better era 30 years down the lane. And the ICMR has also taken some real fantastic steps to curb down the unnecessary hysterectomies, which are very appreciable. So, but those days, especially in Andhra, there is a small area where the Lombardi women, all of them, the uterus were removed. Uterus and the ovaries. So can you imagine the GSM developed so quickly for them and the husbands leave them? So this was what really triggered me to get into menopausal medicine. And that is very, very interesting. So when I started, the information that is available was very less. You're not confident in how to treat these women because we never had the technology that all of you have it right now. 30 years ago, it was, going to some library and picking up books or waiting for some journals and waiting for the pharmaceutical people to come and give us some more information. Of course, things have changed. So now, when over a period of years, I realized that our Indian data is lacking. So when we did our first guideline in 2012, what we did, so we had a lot of discussions, but then what I did was whatever was presented at the post in all our conferences, be it as simple as a poster or an oral presentation, we used all that material for our guideline, first guideline, because I felt that is the real material which had come in. Genuine work done by our people presented at the IMS conference. But I realized that the data is lacking. So that initiative, pushed me into this registry. And I wish more and more people join us because documentation is so important for the success of the registry.
Perfectly said, because we do so much of good work, but the data is not there, the collection is not there. So, thank you for that great initiative, madam. And that is a requirement of today, I would say. Coming back to my topic, MHT, we call it at menopause hormone therapy. So, why was the need there to replace the term from hormone replacement therapy to menopause hormone therapy? A little bit touch of WHI also, if you can give, because many practitioners were taken away. No, we'll not prescribe because we want to have a safe practice.
The fear. Yeah, we recently published an article. There was this special issue in the climacteric for the Middle East and South Asian countries. So MIC, so in that, the knowledge and attitude of women and professionals. So it was very, the IMS. So we had collected the data from about the more than 1,000 IMS doctors about their knowledge and the confidence in prescription. But what happened in that, what we found was people from the IMS had the knowledge, but the confidence in prescription is not there. The fears around cancers and the fear about how to prescribe, I think detailing of the prescription is still lacking. So what is important is, I think, is now implementing the knowledge that we have. So that becomes very, very important. So that I think we are in the stage where we have things in place, where we have the guidelines in place, but reaching out to the doctors and empowering them so that they have the prescription right. So though we started the prescription writing module way back when Dr. Swarna and Dr. Jaydeep was the president, but we still need to put it in place. And so I think I went off into a different track. I will answer your question, which is very, very important. What is MHT and why the name has been changed? The very simple reason, because the post-WHI, the first release in 2002 created a lot of havoc, saying MHT is bad for everyone. But then the data analysis and later on so many other observational studies, the KEEP and the ELITE and all of them so we are in a very good era where now we are confident in saying that when you prescribe a therapy between 10 years of menopause, within the first 10 years of menopause, it is very, very safe in a healthy woman who doesn't have any contraindications. So here we are not saying hormone replacement therapy. We are using that term only for the POIs and early menopause. But when we use it for that 50 to 59, not 50, for us it is 48 to 58, because our age of menopause is different. So within that 10-year phase, you say menopause hormone therapy because you're just giving it not to everybody. It's not a deficiency. Only some people need it. Not everybody needs it. Later on, now luckily we're in a phase where there is, we have enough of confidence that even after 60 or even after 58, somebody wants to continue it, then it is estrogen maintenance therapy. That's a new terminology. Probably you're going to, hear more about it.
So rightly described, madam. So if I have to categorize a woman who is not suffering from mild symptom, moderate symptom, and severe symptoms, so ideally when should we start MHT, and how long we can say, and when is the time that we say we are not too late to start the MHT? I mean, there's a three component of this question. Filing it a little bit more on you, but I think you'll be able to justify, because most of the times we are in the dilemma that should we start, should we not start? And by the time we really are ready to start, it's often too late to go.
Yeah, so I think this is a very common thought in the minds of the clinician. Simple reason because, we are not running dedicated menopause clinics. Most of the time, the obstetrician and the gynecologist is too bogged up with so many other things. So it needs a little specialized attention. So when we start, so there are, some right principles. So we put it in the 2012 guideline where we said that we have to follow 6 right principles, then you can't go wrong. 6 right principles. So starting the first one is when to start. That is first is the right age. So within 10 years of menopause is a time where you can be quite confident in prescribing the therapy without a problem. Then the right woman. I remember Dr. Behram, when I was much younger, I just finished my post-graduation. One of his lectures, he said, MHT has to be like immunization. And we took, that was a time when I was struggling with my POI patients, and I was very impressed. And that is where even the American Physicians Group almost said the same thing, that it's for everybody because it protects. So that was the era. But now we are in a good era where we are more balanced, where we know that it's not for everybody, but some people need it. So it's not just symptoms, but some people need it beyond symptoms, to answer your other query as to the indications. So choosing that right woman, because every woman is different, as different as a thumbprint. No 2 women are alike, because her basic health, her genetics, everything would be different. So you have to choose the right woman. Once you've chosen, then you have to choose the right regime. What regime are you going to give in which phase of her life, whether the uterus is present or not? Then you're going to choose the right kind of the molecule. Which molecule is going to be more effective for her? Which is the kind of route you're going to give her? So, and then you plan the long term. I think I've answered all your questions.
Yes, perfectly right, ma'am. So if I have to start a MHT to my patient, there is a fear of weight gain. Patients do come and say, I am diabetic, I'm having comorbidities, I'm already obese, I'll have more weight gain. And then there are so many fear of having cancers. So I think this is the biggest myth which we face every day. Most of the gynecologists still have instilled in their mind, and we have to be very precautionary when it comes in terms of weight gain or maybe diabetes or the cardiovascular risk. So what is your say on that?
Yeah, I think so. We'll take one by one, the three myths. First is the weight gain, I think, which is the immediate concern. The minute you say hormones, they think you're going to gain, right? Because they have this experience of the much older, the higher levels of hormones. And even then, it doesn't. So we have to tell them that the estrogen that we're using in MHT is 1,000th of the strength of what you use normally in the oral contraceptive pill. And the progesterones are also much more friendlier, it doesn't cause the salt retention and apart from that, in fact, what estrogen does, there is a beautiful study which has shown that there is a loss of 1.2 kgs, in fact, when you're giving 17 beta estradiol with the dihydrogesterone or the natural progesterone. And in fact, the visceral adiposity comes down. So even if there is no change in the weight, but you can assure them that if they're going to eat because they're going to be happy, if they're going to eat because they are, more comfortable after the MHT, that's not your fault. So you have to drive in that lifestyle management along with the MHT to see to it that they don't put on weight. So that's about your weight. The second question was on
Cancer.
Cancer. So cancer, of course, I think the main fear is the breast cancer. Because if the woman has a uterus, you can tell her very comfortably that, in fact, this is going to reduce your risk of cancer, just like your OCPs, endometrial cancer. Breast cancer, I think one of the best way that a doctor can explain to the patient, the counseling, is to go to the British Menopause site. I'm very, very impressed with the infographic on breast cancer. So beautifully they have done it, Archana. It's so simple for you to, I think everybody should have it on the table to explain to the patient because it gives the pictures of the woman. The way the counseling is so easy. Very clearly it says transdermal, no increase in breast cancer, estrogen, progesterone. Because there are studies to, prove that the progesterone and the dihydrogesterone is different from the medroxyprogesterone. CEE plus the medroxy, 4 increase incidence in 1,000. But look at the weight. Obesity, 24 times more. Does anybody talk about it? It's an eye-opener if you're going to look at that. And it is so useful. I find it very useful in my practice, especially for breast cancer. In fact, estrogen alone will reduce the risk by 7. So you can tell them estrogen is not causing cancer.
Yeah. Studies say that it is almost the same risk if you talk about the normal population and the patient who's receiving MHT. The roots is important. The third component of my question was diabetes mellitus and the comorbidities, ma'am. So again, patient fears when we say we are giving you hormones.
So I think because rightly said, because comorbidities are so common in our country. So people just don't suffer from one morbidity. Multimorbidity is kind of so common. They have the diabetes, the hypertension, the dyslipidemia, all three just go together. Well controlled is not a problem at all. And of course, diabetes mellitus is a special issue, Archana, because if you're dealing with well-controlled type 2 diabetes, the oral actually is better. The insulin resistance actually, it favors and it reduces. And the WHO has a beautiful study they have shown how the insulin resistance is down and the type 2 diabetes can be actually downgraded when you're giving it at the menopause transition, one of the benefits. Similarly, the cardiovascular benefit. If she is cardiovascular disease naive patient, but with all these risk factors, it may help actually in a way. The dyslipidemia, this is the only molecule which which increases the HDL, brings down your lipoprotein. So the dyslipidemia, it helps if you're giving oral. But if the type 2 diabetes has problems, then you go for the transdermal. And of course, the progesterones, I think all over, now we have completely shifted to either the micronized or the dydrogesterone.
So, Madam, you have beautifully started taking the terms routes like transdermal, this. So, can we have a little insight what routes are actually available? And
in India, yeah. So we have the oral preparations available, that is the conjugated equine estrogen. Then we have the 17-beta estradiol. Then we also have the estradiol valerate, which is there for oral when you're talking about the estrogen. And the progesterones, you have the micronized, you have the dydrogesterone. Then you also have the levonorgestrel for your menopause transition phase, very useful. And I would also like to talk a little here about the combination drug that we are having with 17-beta estradiol and the Dynagest. Very, very useful in the menopause transition phase, where your abnormal uterine bleeding happens and not related to any, you can say AUBO, that becomes very, very useful. It also helps in the symptoms and also helps in the other problems. So I think that is one area. And for the transdermal route, we have the 17-beta estradiol gels. We also have the spray, but I think now we are having a little trouble with the spray. We are waiting for it to come back with the bank, just like it was there earlier. So sprays, women were very comfortable with the sprays rather than the gel. And then for the vaginal, we have our conjugated equine estrogen cream, and we also have the estriol. We used to have the estriol tablets, and that was so wonderful for our old women who suffered from GSM. But unfortunately, last, I think, 2 years, it's not available. So we just have to, So the counseling and, that gets a little difficult when people find it messy to use the tablets, or they have osteoarthritis, or they don't have help. Then these are a little problematic when you're using your vaginal creams.
Ma'am, once we start the MHT, how long can we give and how do we actually monitor when we are starting MHT?
Again, $1 million question there. No? So, how long to give? It all depends on the indication that you have started with. If you're doing it only for symptoms, then, it's a decision what the woman can decide till what time she wants to take, usually 2 years. But many of them hardly take for 6 months, 1 year, 2 years, and then they stop because they would have heard so many things from so many places. But people who are suffering from severe symptoms, they stop and they come back to you.
Mm-hmm.
My physician said, now you don't take this medicine. Just about a week ago, I had this woman. She's got a Mirena in, and she is on oral 17-beta estradiol. So her endocrinologist told her, you get that Mirena out. Now you're getting into the menopause phase. So you don't need it because she has adenomyosis, and stop the estrogen. So she stopped the estrogen for a month. The Mirena is in place. So she came asking me, ma'am, what do I do? I want to get this Mirena out. I said, but why do you want to get it out? No, I'm menopausal. No, my endocrinologist. But she didn't tell me. Very slowly, then she said, no, my endocrinologist said that get this. Then I said, how are you feeling? Oh, I'm feeling miserable. Then if you're feeling miserable, why do you want to go off your estrogen? So then she came out with the story that the fear which was instilled, about the bad effects of hormones if you're taking for a longer time. So I think this is one big myth. If they are well monitored, I always ask my women, I asked her, if you're taking your thyroid supplement, will you stop it? No. Unless, or diabetes. See, sometimes when they're early diabetics, not really a bad diabetic, just about a diabetic, maybe for a short time, they may need some help. But lifestyle in that early phase of the lifestyle completely helps. Then maybe you may stop your medicine over there. So those are the areas where the MHT can be stopped. But I think it's a little as long as you need it. For me, I've got patients who have been on therapy for 20 years as well. And, slowly. So what we do is the dosage is very important. You can't give the same dose that you started off with. So the dose has to be tapered and reduced very much as the woman ages. And now, of course, you have excellent articles and excellent evidence to say that as the woman ages, if you're going to convert them into transdermal, the chance, because VT is a real risk anytime, and VT risk increases as you age. So you have to be more careful there. And of course, the stroke and all of that. So a healthy woman without comorbidities, it's a shared decision making. So I have women who are 60 plus and still on therapy.
Yeah. So this is something when we talked about like GSM, you were saying, ma'am. So if a lady is 60, she's still suffering from vaginal atrophy, can we give the local estrogens comfortably in this patient as well?
I think the local estrogens has to be popularized not only among the gynecologist, among every specialty, the urologist, the general practitioners, anybody can prescribe it because the only contraindication is an active breast cancer. So ER negative breast cancers also you can give.
Yeah,
And ER positive, of course, is a specialty, and not everybody should be prescribing. But I think that's the only area, that is one prescription which can be given by anybody. And, if somebody is with 105 temperature, you give them a paracetamol, they'll bless you, isn't it? So this is something like that, I think. Old people will bless you if you treat them with this medicine.
So I think this is a very good take-home message that don't let her suffer silently, because GSM and vaginal atrophy is something which is very, very troublesome for a woman. So even if we prescribe, we should be giving it with authority. And I think she doesn't need to be monitored by TVS or endometrial lining. Nothing has to be monitored. She can be given it. Just to give is what madam is also advocating right now. So we should not hesitate.
A word of caution over here, Archana. Luckily for us, we are in India, we just have the conjugated equine estrogen, and we have the estriol, which is low potent. We don't have the 17 beta estradiol ovules, and 25 micrograms of the 17 beta estradiol, where sometimes they need more monitoring. Whereas I advocate in a full-blown case, you can start off with conjugated equine estrogen, then just shift over to estriol, which is low potency. So the safest would be estriol for all those patients whom you're more scared to give. So then you don't need the monitoring. And we have data for 1.5 years. And of course, you have the data from observational studies, but the RCTs are only for 1 year to say for how long to give. But still, I think the world over now, everybody is of the same thought. And in fact, recently, I think the black box warning from the FDA, where they, were a little cautious about the use of the vaginal therapy, has also been removed. So even if the FDA has removed it for the USA, that does impact the entire world.
Yeah. Because we over-the-counter available drugs to make you more beautiful. Nobody thinks about it and just gobbles it readily.
Yes, with all the parabens and all the
everything is going on, and they are more harmful if we compare to what we are offering our patient for relief of GSM. So
True.
there is one more segment of MHT which I would like you to discuss with us for the benefit of the audience. That MHT is not only for the acute symptoms, for the long-term benefits of MHT if you prescribe at the right time. In terms of maybe
very, very controversial area, Archana. But you must now, I'm very excited about the guidelines which we are going to come out with. We are updating the guidelines. So 2026, we are going to, come out with the publication of the new updated guidelines. And I'm very excited because we have been bold in our favoritism towards the bone health, even in 2012. So 2012 also, if you remember, the guidelines said the prevention and treatment, where, most of the guidelines were for prevention. Then the International Menopause Society also said, yes, you can, that's not just prevention. But every time we were more, cautious about saying only those women with symptoms and bone protection. Asymptomatic women go for the bisphosphonates. So this time we have been a little more bolder. We have come across with good evidence to say even asymptomatic women in the early menopause transition, if she doesn't have any contraindications, probably you can offer her the MHT or the bisphosphonates, whatever you like. So that could be the first line of management. And this was also given by the, the UK guideline 2024. So on bone health. So they've also said that MHT can be given as a first line of treatment, and that was amazing.
Yeah, because we know the bone matrix is important. Once it's gone, it has to be orthopedic osteoporosis treatment only.
Correct.
MHT fails.
It also helps the collagen over there. So there are a lot of benefits, and I always wonder, the terminology is post-menopausal osteoporosis. So when you're saying post-menopausal osteoporosis, because of estrogen deficiency, what is the logic? That you have to replace the estrogen at the transition. At the transition. Okay, beyond 10 years, because the data is not very comfortable after 10 years, you're not going to start MHT that late. Somebody's taking it, they're comfortable, you lower the dose and you take it. I think that's sensibility.
Yeah.
Along with the evidence. But now we have evidence also. So, the sensibility and evidence are going together.
Waiting for that 26 guidelines very patiently, madam. I know we'll be rewarded with so many good outcomes in later coming years. So there are absolute contraindications, madam, where you select the patient that they are not to be given MHT.
Yeah, I think very, very clear. Any estrogen dependent cancer, I think those are all common. So I'm not going to go into the ones which are really, everybody knows about, the porphyrias and, the other ones. But I think what I'm going to, for the practitioner, is to understand cardiovascular disease, high risk of cardiovascular disease, you're still going to be very careful. So moderate risk, so established cardiovascular disease, you're going to avoid hormone therapy as of now. And second is high risk of breast cancer, you're going to be very careful. So this brings us back to a very important, thought, that when you need time to spend with that woman, because the first contact, you're going to understand the risk factors. If you don't understand the risk factors, you cannot prescribe hormone therapy. How will you know whether she is at high risk for cardiovascular disease, high risk for breast cancer, unless it's not investigations alone? It's your history taking, it's your risk assessment that you come out with a complete picture as to what risk this woman has. So high risk of breast cancer, high risk of cardiovascular disease are additional components which you will be more careful about when you think about hormone therapy, apart from the regular ones which are there.
So, madam, as a word to the gynecologist, how does a basic gynecologist monitor a patient when she's putting her on MHT? What?
Yes. First contact, the first contact has to be, maybe in my practice, there are no guidelines as such, but then we prefer to call them back after 1 month to make sure, that how they're feeling with it. Because it generally so when you put them on hormone therapy for severe symptoms, you tell them that you're not going to get instant results. The results are going to take minimum 3 weeks, and it may take up to 2 months also sometimes. But at least a 50% you're going to start off with. So you want to know whether she's happy with what you've given it. The confidence building, and just to understand whether what adverse effects. Sometimes they have breast pain, sometimes they may have unscheduled bleeding. So you're addressing all those issues immediately so that she doesn't lose faith in your treatment. So I would like to see her after 1 month. Then you must see her after 3 months, then annually. And when you're just monitoring her like any other person.
The regular health checkup investigation.
Regular health checkup, yeah. So it's actually beneficial because then, you're making sure she goes through her annual checks, because you keep changing. She may not have had any risk for any disease when you started the therapy. Maybe 2 years down the lane, you may think twice before giving her the therapy.
So that is very important. The word is surveillance, which has to be instilled into the mind of our patient whenever we are starting, because once for all is not going well with MHT. It has to be regularly monitored.
Very simple, Archana. You tell them that if you are on an antihypertensive therapy or you're an anti-diabetic therapy, are you not going to see the doctor? Are you not going to get your blood sugars, your blood pressure, your lipid profile done? As simple as that. MHT is also something like that. You have to be monitored.
So, as you rightly said, that the health checkups are very important when we talk about any woman for any aspect, leaving aside the comorbidities, because sometimes we need to do the health checkups to understand that we are normal. That is also an important aspect that we should give to ourselves that. So, madam, if I have to think about non-hormonal options for treating the menopause, what are they, and ideally when should we offer this to our patient?
Yeah, I think there are sometimes women, even if they are eligible for hormone therapy, they don't want to take it. They would have read so much about it, or the fears and whatever it is. So that is one group, and there is the other group where you have the contraindications where you cannot offer them the therapy. So there are the SSRIs and the SNRIs which we have, and the gabapentin. So these are the three groups. So when you are talking about I've straight jumped to the non-hormonal prescription therapies, but then CBT is coming up in a big way, Archana. And I think I feel that we should really promote this CBT because it is so useful, and it is that domain of the Bell's hypothesis where I talk to you about the psychological aspect. So the CBT is what the woman needs, and if you're going to help her out, then she will be able to do the self-help. She may not even need your hormone therapy. So CBT and your mind-body relaxation, yoga, and the exercise, the therapeutic lifestyle. And I think the International Menopause Society is doing a fantastic job of this year. They have put all the thrust on therapeutic lifestyle management. And they have a beautiful article also, which has come in the Climacteric, which all of you should read it. Because I think lifestyle management is affecting not only the menopause, but it is also helping so many comorbidities and the mental health. You're going to feel good finally. So that is one part. And of course, you have the non-hormonal prescription medicines, like I said, and you choose the medicine depending upon the need of the woman. But you're not going to give these medicines long term, though the doses are very, very smaller compared to what you would give for, the full-blown psychiatric problems. But even then, you're not going to use them for long. So I think, but we are still waiting. Actually, we were pretty excited. The Fezolinetant was supposed to be coming into the market, but I think it's going to take time. So, yeah, so because we have got very exciting results from world over, how good it is, especially as a non-hormonal alternative.
So, Madam has rightly said, when we talk about the CBT, there is one term which affects the menopause very much, I would say, far, far beyond actually, I would consider midlife also in today's era, insomnia.
Insomnia, very, very, yeah.
Many of the patients who will come in our OPD crying, weeping that I'm not feeling well because I'm not able to sleep well. So is MHT helping these patients as well?
That's a very difficult question to answer because you have to be sure that the sleep is related to the menopausal symptoms.
Yeah.
Sleep can have so many dimensions, as simple as addiction to your gadgets at night. I mean, that's a new addiction, and that itself can, take the sleep off because it's going to give you all kinds of thoughts at night. So I think it's not just about MHT. MHT would figure only if it is associated, say, with the vasomotor symptoms causing daytime sleepiness, or if you have ruled out every possible cause and the sleep problems have surfaced at the menopause transition. Very, very small segment. So I don't think you should be, promoting MHT only for sleep.
Yeah, that is the right thing.
Yeah, where it is more taxing for the treating doctor to actually, so probably you should take help from your physician friends as well, or the psychiatric friends, to colleagues to understand the cause.
So I think Madam has rightly said, if she's having any vasomotor symptoms, especially hot flushes and all, that need to be addressed. And if she's waking up at night because of the hot flush and other things, and especially sometimes she's having pain, joint pain, she wants to urinate. Before she goes to urinate, the urine passes off because physically incapacitated. So I think that is where the history stands, that if insomnia is because of any other problem related to menopause, then only the MHT is going to work. Otherwise, I think CBT, giving her a good sleep hygiene, as Madam said, we do dieting, we do upvas, we should do gadget upvas also after 6 p.m. every day. So that would help our patients more when we talk about insomnia. Ma'am, a little hilarious or maybe a very practical question out of the box I want you to answer. are the gynecologists really good patients, or the layman is a good patient when you're prescribing?
Uh, I wouldn't really, I think it's very personal because I treat both the segments.
Yeah.
And because I also do bone health, so I have that segment of gynecologist who whom I treat for bone, and also for the symptoms. It's actually, for me, it's easier to treat the gynecologist, I think, because they understand. It's easier to convince them because they are well read, and especially if they're going through a problem, then they're more convinced in what you're saying. So for me, I think it's easier to treat your colleagues and the younger.
Better follow-ups, madam. They do stick to the regime.
Yeah, some of them do. I think that is again very personal. Some patients are also, you see, they follow your instruction to the T. And there are some who will just forget. It's not, they don't have the intention, but they forget what they have to do. And some people just don't want to take the medicine. They take it as long as they feel good. So you have different varieties, and I think it's nothing to do with your profession.
So, just taking it a step further, how does a healthcare provider communicate to her patients to tell them that it is essential component, and what conversations you would promote when we talk about the menopause health?
Menopausal health. So yeah, I think any woman who walks in, we used to say earlier 40 plus. But this time around, when we are doing the guidelines, we're realizing that it's 35 plus in India. In India, it is 35 plus with the kind of morbidities that we're having. And, we age 10 years earlier, actually. So any woman we say walks in at 35 plus, start talking to them that don't talk to them about menopause. But then at 35, you're going to talk to them about lifestyle management. You're going to talk to them if you have a genetic history of any problems, whichever problems, say diabetes, hypertension, comorbidities, please get yourself checked. You don't have to do it yearly. There are some protocols to follow. Then get your cancer screening done. Very important at 35 plus. And very important, late marriages. So you have to think about fertility. So these are the issues you start off at 35 plus. And then you tell them that this goes on and there will be changes. And 40 plus, there is more change. At 40 plus, you have from early menopause transition, you're moving on. And that is where, your bone, your muscle, and when you're going into the late transition, your lipids. So there's going to be an effect of estrogen all over your entire body. So you will need to just come and get your health check done. Because if you're managing a healthy lifestyle, you're inculcating a healthy lifestyle at 35, she may not need any therapy, even the menopause hormone therapy as she ages.
Yeah. So I think lifestyle is something we have to hammer and reinforce. That is
Absolutely.
very, very important.
We have so much of obesity, Archana.
Yeah, obesity and junk food and everything, the lifestyle.
The PCOS is rising like anything.
So PCOS, there's always an overlap in adolescent and menopause age. So we are like literally difficult to differentiate, but lifestyle is the answer to most of the things. So looking ahead, madam, from this point, what we discussed actually, what are exciting new research or developments you are seeing from in the field of menopausal health and the hormone therapy, which you would like to maybe it's premature, but we are also looking forward what is going to come next.
Yeah, I think Dr. Sunita, like you said, the regenerative medicine. We're looking forward to the regenerative medicine, the use of stem therapy and the use of the ovarian cortex implants. That's already been done for cancer patients, but for menopause, whether that will again completely, there is no role for hormones then, and for how that's going to work. So it's very exciting to even think about the endocrinology and how all this is going to work in future. So of course, that is, we can never say how long. Things are happening so fast, Archana. Before you realize there's so much of research going on. I think that's one thing which is very, very there. And then the new transdermal preparations which are going to come in now. Because now there's a lot of evidence about the safety of the transdermal. So I'm sure there are going to be a lot more in that area where different formulations and patient-friendly formulations are going to come in. Probably also some preparations which you can use just like your contraceptive implants. You know, implants were there once upon a time, which went off because of many reasons, but they may come back with a different picture in a different mold. And then you also have something very exciting, which I was talking about. I forget now. AI. So I was reading that AI in the DOP study from Europe, the osteoporosis prevention trial, they in that particular model they use the AI. So they use the genetics base of the woman with her genetics, her clinical output, and they could pick up those women who would benefit with estradiol on bone. You know, the algorithm, the data that they have, and it worked. So this AI algorithms are going to help you understand which woman is going to get benefited by the therapy or which woman may not be benefited or would be at risk. So can you imagine? I mean, you know, you can predict that this lady, you can be more confident with your hormone therapy and this lady is better not to give. So that's
we are progressing and need to catch the bus because now the speed is more. So thank you, ma'am, for that insight. But I would like this. Do you remember any incidents, anything funny, or maybe something which you remember in so long practice where that is still in your mind? Would you like to share with us without taking the name of the patient?
um, I don't remember any hilarious moment.
Or maybe anything you would like, something which was a thought-provoking. As you said, hysterectomy in that special village.
Yeah. True. Hysterectomies was one. The fear, I think the fear of cancer, especially the breast cancer patients, I remember more than the, because most of them come with, they are in pain and people don't understand them. So for them, it's only a lot of gratitude when they come back. So I think that is one area, and you feel very satisfied at the end of the day. I mean, that's what I would rather say, rather than give you any quote or any incident about the patients. But treating these older women with a GSM and treating the younger postmenopausal women is as satisfying as delivering a baby. For me, delivering a baby was so satisfying, But then I realized that treating this segment of women is also very satisfying.
You're very right, ma'am. When she comes back and says this 5 years when I started with the AGSM, the therapy, they were the best days of my life. That is actually gives you a little extra kick that you did something good for the society. So before we end our conversation, madam, last few pearls of wisdom from your side.
So I think it's, I mean, first I would like to congratulate Fogsi for having the midlife committee, a focus committee to work on the thing. And thank you, Archana, for bringing out so much in this 1 hour. So you have literally, covered most of the topic of hormone therapy. And probably we should now pay attention to spreading the guidelines, because when we have guidelines, so it's easier for everybody to follow the protocols. Because whenever there is a gray area, it's more important that everybody follows the protocol. So for the gynecologist, I think every gynecologist will be able to prescribe hormone therapy because you're used to it. You've been prescribing hormones at puberty, for all the AUBs, for contraception. So your base is so good. You just need a little time, a little refresh, that's all. It's not rocket science like a laparoscopy or infertility. Much, much simpler. You just have to put in a little effort. Yeah. Everybody can practice menopause. It's not at all difficult.
Thank you.
I think that is my take-home message for every gynecologist.
Thank you, ma'am. So MHT should be followed as immunization, as you already said, but we have to be rational and we have to select our patients.
Not like immunization. Very, very selective.
Selective. So that is the right person, right time, and right therapy. That is what we advocate. Because I think now 60 is the new young. So when you are young, you should be feeling young and your body should perform as you're young forever. Thank you, Meeta ma'am, for this 1 hour brainstorming session. Many of the myths have been solved. And I think our audience would also be benefited. So before I sign off, good night to everybody. Warm wishes for Happy Diwali. And
Happy Diwali to everyone. And thank you so much, Archana. I really enjoyed it. It was a conversation which was so nice. I enjoyed answering your queries. Thank you, everybody, for joining in. And thank you, Archana. Good night and happy Diwali.
Thank you so much. Thank you, support team. Thank you, Sunita ma'am, for giving this opportunity. Looking forward to upcoming event tomorrow, 8 p.m. again. Good night. Bye-bye. Thank you, ma'am. Support team.